So we shall now go on to our next speaker, Dr. Abadan Khan Amitava, and he's a professor of, had already introduced him, and he's going to talk on a very interesting topic, plication and old procedure reinvented. On to you, doctor.
Thank you, ma'am. So without further ado, I'll talk about plication, and it's true that it is really nothing new, but we've got it back into action, so to speak. There are many options for tightening muscles. Most of us are doing resections straightforward. Some of us might be advancing a muscle now and then. And the word tuck is usually used, goes with the superior oblique. Plication is also a form of tucking, really. It's just folding a little portion of the muscle tendon complex near the insertion. Now, why I did some work on this was when we were doing and researching the Mojo's minimally invasive strabismus surgery, I was really surprised to see that most of the time Mojo was plicating. And as you see the two enlarged pictures, this is one day after the plication, and there was on the medial aspect of the eye, and the eyes looked remarkably quiet. They didn't show any apparent bulge. And the congestion were very, very similar to any other eye. And I was so impressed that I decided to go and try plications myself. Because although I had thought of it earlier, I always thought there would be 3 layers of muscle tendon at that point, and there should be a bulge, and it should lead to some kind of blemish at that point of time. As you can see on the left, there are some advantages. It will cause less disruption of the anterior segment circulation, and there'll be lesser post-operative reaction. Right also says that, which is obvious, since you're doing no tenotomy, there's lost muscle is not going to happen. And there is also an option of reversibility in the immediate post-operative situation if you, for some reason, feel you messed up. I also felt at that time that it would be obviously less bloody since we were not cutting muscles at that point of time. And it shouldn't be more difficult than a resection. And it just might be a tad quicker. There would be little bleeding and things like that. But as Professor Pradeep Sharma pointed out in his comments on the article we published, there used to be cheese wiring, but that was when muscles were attached to the muscle tissue only while you were folding it. But since everybody is now doing muscle to sclera, that cheese wiring is more or less over. But there was always concern of some undercorrection, which may lead to more reoperations and some drifting off of the muscle in the long term. And as these pictures show about iris angiography, on the left, the pictures above is to do with the pre-op, and the one below are about under 40 seconds after surgery. And if you can see, you'll be able to see here on the top, let me just take the pen color here. Yes, and so you'll see here on this portion, after the tenotomy side, that there is an absence of vascularity within 40 seconds of the surgery. The pictures on the right, on this side, they are before and after doing plication, and absolutely fantastic circulation. So there is no doubt that circulations are better with plications. But compared to the angiography, which is an invasive procedure, the OCT angiography now gives you an option which is non-invasive, and moreover, it can be done on both the eyes more or less at the same time. It allows you that thing, and it gives you this delightfully thing which are numbers quadrant-wise as a percentage of vascularity, each quadrant-wise. And why I like numbers is because numbers allows great statistics. So if people who have access to ocular coherence tomography, they can do further studies doing angiography with and without plication. And as you can see in this picture, the one on the left is the inferior, you can see it on the inferior aspect, the vascularity, and this is after tenotomy. On the OCT angiography, that the vascularity has gone down. Now here's what the options are. You can either fold the muscle under the muscle itself, which is what a tuck would be appropriately called. You just tuck it in, or the loop might hang outside on the outer aspect of the muscle. We of course favor the technique which is shown on top. We tucked it in, but remember something would be needed to help fold the muscle underneath, because as you're trying to lift the muscle forward, the muscle loop itself tends to also move forward. So you need to keep using something to push it back. And as I can show you in these pictures, we took locking bites. We identified the area from where we would do the resection we would have done, took locking bites, and then in the second picture, in this one, we took subsequent bites just ahead of the insertion. And this instrument that you see here, this little pipe-like instrument, was nothing but the intravenous, cannula, the needle, which had been broken off and then bent so that it formed a little, a useful instrument for us to push the loop underneath the muscle as we close the sutures, and that's how we got the surgery done with the loop. That means we tuck the loop under the muscle. And as these pictures show, and we did a randomized control study with 22 in the resection and 18 in the resection plication group, whether on the first day or the 2 weeks later or the 6 weeks later, 6 to 8 weeks later, we found no significant differences in the inflammatory scores, no significant differences in the success rate. Even the alignment change per millimeter of muscle was similar in the two groups. Jaspreet from the PGI Chandigarh had an interesting paper on a very similar line, but they had access to the UBM, and what they also did was 1 year later, so they had long-term follow-up, they looked for post-operative drift. So the one above is the recession, and the one below is the plication, and they reported no differences in the minimum drift. There were just insignificant drifts in both the recession group and the plication group. So there is enough evidence that the post-operative drifts are nothing very different from recessions. Then I came across this.
You have 1 minute remaining, sir.
Okay, in 2020, where there was a meta-analysis, and with the compared 7 studies, each of which had follow-up for beyond 6 months, and they had comparative success rates, comparative drift rates, comparative reoperation rates. There was again no real difference. So at the end, I still think that the applications are at par with resection, and they particularly should be used if you're doing more than 2 muscle rectus surgeries. Wright, of course, has also suggested a mini plication. There are now papers saying that you can do adjustable plication, and I'm now toying around with the idea of using plication along with certain vertical offsets, to cater to some of the alphabet phenomenon when we don't need to touch the obliques. Thank you.
Thank you. Thank you very much. That was a very interesting presentation. In fact, I find I'm really enjoying myself. Is there just one question before Veena takes on? Is there any concerns in plicating a lateral rectus? Would the resection be better in this muscle?
I really haven't looked at it at that point of view, because when I do the plication, I find no difference really. I've done plication of the lateral rectus, I've done for the medial rectus, and I've had no issue with them.
Dr. Veena?
Yes. So thank you, sir. It was a very excellent presentation. In paediatric splints, whether do you prefer application?
No. I'm not. I haven't tried it out at all, and I haven't thought of doing it in paralytic strabismus. No, ma'am.
Have you done on vertical recti, Dr. Amitava?
No, Dr. Pandit. Again, no, I haven't done plication with vertical recti. I'm largely I've done plenty of them, but all on horizontal recti.
All right. I think as you gain more experience, I think you can move on.
Maybe.
Yeah.
We feel like there is a small bump when you do application. Is it acceptable by the patients?
Absolutely. There is really no bump. I mean, even before I started doing this, even 20 years ago, I had thought of holding this muscle, and I said, we can't have 3 layers of muscle tendon there. It wouldn't work. But only when I saw Mojo's results, I realized that it actually works. So you see the thing of the pudding is in the eating of it. So if there is no bump, we don't see it, and I didn't see it either. The patients were equally happy.
But there are concerns about long-term drift. I think some long-term results, I think, are slightly there's a drift, I think.
But I quoted Jaspreet's paper. You see, even a year later, they did UBM to see where the muscle was after a year. They again find no difference.
But 1 year is a short time, and the number of cases must be very small. Okay, so I think more studies need to be done. Maybe
I would say that the past 3 years, I mean, I personally, and I remember Dr. Pradeep Sharma, we have virtually entirely shifted to plications. I mean, I have to actually know an indication for resection to do a resection. Otherwise, it's plication.
Yes.
And of course, I can't give you exact numbers, but there is no change either way, increase or decrease in residuals or overcorrections. There is a chance of an error of either.
Yes.
You would have an overcorrection because you are passing the suture anterior to where you would pass in a resection. You pass it deep in the stump when you do resections, and here you pass anterior to the insertion. So you have a risk of an overcorrection. And as you point out that there is a risk of a little loosening of the suture, especially as now we have all gone on to doing vicryl for plications instead of using ethibond, which was the earlier concern. So there is that little risk that it loosens up and it causes a little undercorrection. But like I said, I can't give you exact figures, but we haven't found anecdotally any increase in either over or undercorrections.
Any reversal? How easy it is to reverse?
Oh, very, very. In fact, I have gone back and reversed. I think my longest time when I have reversed it was, I think, 3 weeks or so.
And what about the resurgery? Sometimes say it's a.
I have opened up and I have replication. I have done, year or two later. I mean, of course, in resected muscle, we frequently do plications, but in a plicated muscle, we have gone on to do a replication. But opening was the concern. And like I said, I've done it up to 3 weeks. Beyond that, I haven't thankfully got the opportunity to try.
No. What I meant was if you have to sometimes like resected muscle, you can easily recess. Should there be a consecutive exo or eso? How easy it is that? Is it easy to recess it back with that whole?
Plicated muscle, like I haven't had the experience. Like I said, plicated muscles, I have had an opportunity to open and to replicate.
Okay.
I haven't had to recess. I mean, it was early, so I haven't had something which I have to worry about so late in the post.
Dr. Rohit, I have done a few this thing where I had to release the plication because there's an overcorrection.
Yeah.
So it actually almost works like an adjustable suture surgery itself. So you can just do a small plication, and if you feel there's an overcorrection, you can easily release it. And one more thing I would like to ask Dr. Amitava. Actually, instead of folding inwards, I've actually done it folding outside also. The folded muscle is on the upper part instead of going behind. And I have seen no difference in the result. It works equally well.
I'm sure it works equally well, because when I initially started piloting this, before I went for a formal study, so we were also leaving the loop, on the outer surface. You're right. I also found no difference.
Thank you very much.